Talking about the blood infections part 2. So I'll taking about dengue right now. Dengue, well, the causative agent for dengue is dengue virus, which is about family Flaviviridae. Then it's an enveloped virus containing single-strand RNA. The vector is Aedes aegypti, which is the mosquito. There are different type of mosquitoes which cause a disease like Anopheles mosquito, Culex mosquito, and Aedes aegypti. Aedes aegypti is the one which causes dengue. The transmission cycle, man and Aedes are the principal reservoir. Pathogenesis is there is primary dengue infection when a person is infected for the first time with dengue virus of any one serotype. There are two types of serotypes, but for in primary dengue infection, any of the serotype, type 1 or type 2 serotype can infect the man. So months to years later, the infection again with the person is again infected with this, with some other dengue virus of another serotype. If the person was first was affected with one serotype, then the second time after months or years later he gets affected with the second serotype. This time no, it will be more severe dengue he will be having. That is called as the secondary dengue infection. So there is primary dengue infection with one of the serotype. Second dengue infection, the person will be infected with. If the person is infected with some other serotype, he will have more severe illness. That is called the secondary dengue infection. So what are the clinical classifications? There are three clinical stages. There's dengue fever, then there's dengue hemorrhagic fever, and then there's last one is the dengue shock syndrome. So what is first in dengue fever? There's abrupt onset of fever. There's a biphasic. That fever is also called as biphasic fever or breakbone fever, or there is called as saddleback fever. There is macropapular rashes over the person have macropapular rash over the chest and the limbs. There will be severe frontal headache. The severe frontal headache is because of dehydration actually. A person will be dehydrated, he'll have low platelet count and all, otherwise he'll have the severe frontal headache. Then there will be muscle and joint pain, there will be lymphadenopathy, and there will be retroorbital pain. Then the dengue next stage is dengue hemorrhagic fever. It's called hemorrhagic fever because there will be high continuous fever. Hepatomegaly will be there. There will be thrombocytopenia. When there is thrombocytopenia means there is low platelet count. Once there is low platelet count, there will be high chances of bleeding spots. There will be bleeding, and the evidence of hemorrhages will be there. So, like if there will be nasal mucosal hemorrhage, or there will be mucus from the oral like mouth, oral mucosa. Then there will be skin bleeding from the gums. There will be bleeding from any skin. If there is slight trauma, there will be bleeding because there is no clotting. The platelet is deficient. So that's the important needed for the clotting. So that won't be clotting process will be affected, and this will lead to bleeding. That's why when the person with dengue comes with a low platelet count of about like 20,000, 10,000, all we don't like if the patient is not able to have food or anything, we won't give NG tubes, or we won't put, or we won't do any oral invasive procedures because it will cause bleeding. And next is dengue shock syndrome. So dengue fever is over, dengue hemorrhagic fever. Then next is dengue shock syndrome. Dengue shock syndrome because the person will have very low platelet count, then they will be having bleeding or somewhere else in our body. We won't know where the bleeding will be there. Sometimes it may be in the brain, or it may be in the internal organs or anything. At that time, the patient will be in shock. So during the shock features will be like rapid and weak thready pulse will be there. So when you look at the pulse, it will be he'll have tachycardia, but there won't be any volume. It will be weak thready pulse. There will be narrow pulse pressure, and there will be, since there will be weak thready pulse and there is no proper blood supply to the peripheral limbs. First, the peripheral limbs will be decreased blood pressure. That's because it's our body's homeostatic mechanism. So the person will have cold and clammy skin, and there will be respiration will be irritable. Then in pregnancy, if the person has dengue, there will be perinatal transmission can occur. It can cause symptomatic infection in newborns. Present with the patient the baby may present with thrombocytopenia, the fever. If the patient may have ascites or pleural effusion in the first week of life. Then it says lab diagnosis. So what's the diagnosis? Lab diagnosis test we do. There's the NS1 antigen detection test. You must have seen a person with dengue. The first test we do is the NS1 antigen, because is the NS1 antigen test will be able to be detectable in the day 1 of the fever, and it remains positive up to 18 days. No other test we can do. So NS1 antigen is the best test and the first test to be done in a dengue patient. So if a patient comes with like fever with generalized weakness and all the symptoms which I told you, he's having he can't get up from the bed, he's finding very weak myalgia body, especially he's having saddleback of fever. There's a breakbone fever because he's having so severe fever that he feels that his bones are getting broken type. That much high fever, myalgia he'll be having. That is a feature of dengue. So what NS1 antigen detection test is done? We do it with ELISA or immunochromatographic test is done. Early detection of infection detectable from the day 1 of the fever and remains positive up to 18 days. Then it's a highly specific test because if the patient is positive, it will show positive. If the patient is negative, then we must do other tests like antibody detection test. In primary infection, IgM antibodies appear first and disappear after 90 days. IgG detectable in low titer. So some test one antigen test. If you look at the reports, it shows that IgM antibody test we have to do. It sometimes they do. So is the IgM antibody test is the first which appears, and it is the preferable test for antibody detection. In secondary infection, IgG antibody. If the patient see first time I told right primary infection, secondary infection. So if the secondary infection right, it is the IgG which is detectable much earlier. So I say IgG is actually present in a chronic stage. So IgG antibody titer rises rapidly when there is secondary infection. Other type of test we do is MAC ELISA, which IgM antibody capture ELISA is called IgM antibody capture ELISA. Then molecular method we use is RT-PCR. What's the treatment? Dengue, no, there is no specific treatment. There is only supportive care. So if the platelet get reduced, we give fresh portion plasma, or the platelet rich plasma we give in IV, and we do I give IV fluids for to maintain the volume of the blood and to reduce the generalized weakness. Then for malaise, fever and malaise, we just give paracetamol, and for generalized body pain, we give paracetamol so that the patient really have reduced body pain. And headache and all, dehydration with IV fluids should be given. The next is chikungunya fever. Chikungunya fever, they can ask you for 2 marks or 5 marks question. So like it is a common fever which is found in Kerala, Karnataka right now. It's from the family Togaviridae. Virus is chikungunya virus. Vector again same vector Aedes aegypti. As that's why in rubber plantation areas and all, you find that dengue fever and the chikungunya fever is very common because they grow in the environment like water. The water is actually collected in and kept there. It will have high chances of growing Aedes aegypti grows in those water. So it is common in like rubber areas, rubber grown areas or farming areas. You find this chikungunya fever and dengue fever more common. So vector is Aedes aegypti again. Transmission cycle, 2 cycles are there. It has an urban cycle and a jungle cycle. Urban cycle is between humans and the Aedes aegypti mosquito. Sylvian cycle or jungle cycle is between monkey and forest fish of the Aedes. So what's the clinical features? Incubation period is about 5 days. So these clinical features help you in the question. So what the patient the patient had a severe fever with usually chikungunya actually they will not give for 10 mark questions. They'll usually give for 5 marks or 3 marks. So they'll directly give you chikungunya fever and write about shortness about chikungunya fever. Mostly they'll ask you for 2 mark questions. You just need to know the symptoms. Like most common symptom is fever with severe joint pain which worsens at the night, and there will be headache. Mainly it is arthritis, and this arthritis it actually affects the small joints, and it mainly affects during morning season when the patient gets up in the morning and daytime. This pain will be very high. And one more feature of the chikungunya is the chilk sign, that is brown nose appearance. That is high. There might be hyperpigmentation of the centrofacial area, increased intraepidermal melanin because of there is increased intraepidermal melanin deposition retention. And actually this chilk sign actually or the hyperpigmentation of the skin over the nose, it's actually not permanent. It will recover after 1 week of the illness. After 1 week, it will recover. The next is chronic stage. There will be persistent joints. Whoever affect one or the other person during the chikungunya outbreak in Kerala has been affected with chikungunya. Any one of the relatives will be there. So they persistence? They have persistent joint pains. As a high risk groups are mainly newborns, older adults, or with patients with comorbidities. They'll have a chronic symptom of joint pain. Now also they'll be having, after so many years also, they'll be having persistent joint pain. So lab diagnosis, what's the lab serum antibody detection? IgM appears 4 days of the infection, lasts for about 3 months. IgG appears late and lasts for years. MAC ELISA is done. IgM antibody capture. Molecular method RT-PCR. Hematological finding we see is leukopenia will be there with lymphocyte predominance. thrombocytopenia will be there. Will be elevated ESR and CRP because these are acute phase reactant proteins, and this actually joint pains will help with it's a arthritis type of joint pain. That's why the acute phase reactant proteins will be elevated in these patients. For the treatment again, there's only supportive treatment. For the joint pains, you give aspirin, dolo, and other medications for supportive care, fever and control, or dolo you give, nothing else. The next is Kashmir forest disease. So this Kashmir forest disease is mainly found in the endemic belt of Kerala and the Karnataka, especially near the forest areas. Near the Karnataka forest areas, Kashmir forest disease is found. Especially in it was most commonly found in the Western Ghats area. So Kashmir forest disease is actually they'll ask you for again 2 marks. It's also called KFD. Family is Flammiviridae. Vector is actually heart tick, and the host is mainly the monkey, rodents, and squirrels. That's why it is found in the forest areas. So monkey is actually the amplifier host. Seasonality is in dry months because during the dry months, like November to June, is the people who go inside the forest for grazing the animals, and they go into forest for collecting firewood. So there is a time when the this disease spreads the most because they go at this during the rainy season. They won't go in the forest. They mostly go in the summer for the grazing of other animals in the forest. That's the time, because that's why the seasonality is common in the dry months. And the situation in India, endemic in the districts of Karnataka, Shimoga mainly. But some cases have been found in Kerala also, near the Western Ghats area, near the Karnataka area. We have seen positive cases. Incubation period is about 3 to 8 days. First stage is actually hemorrhagic fever stage. Acute high fever with malaise and frontal headache will be there. Hemorrhagic symptoms like bleeding from the nasal cavity, throat, and gums, GI bleeding can be seen. So you will get confused with the. You may think it is a dengue actually. Then during the second stage, there will be meningoencephalitis. If in hemorrhagic stage, if you don't control the disease, then the second stage there will be meningoencephalitis. It lasts about 7 to 21 days after the first stage will be seen, meningoencephalitis. So what's the lab diagnosis? You do RT-PCR and real-time RT-PCR. There will be leukopenia, there will be thrombocytopenia, and there will be decreased hematocrit. And during the CSF study, there will be abnormal CSF study will be seen. Other treatment again here, there is no particular, there is no specific treatment for the Kashmir forest disease, and there is only supportive treatment is given. So vaccination, what do you do? There's a vaccination, killed vaccine is used, and especially the people living in the Shimoga belt or the belt near the forest, the Western Ghats area, they get vaccine. They can get vaccinated, and the vaccine is actually a killed vaccine is used. This is Ebola virus. Ebola virus also they can ask for 3 marks. Causative agent is actually Ebola virus. Vector is fruit, bat, or apes or monkeys. Ebola virus, you have seen in your book, I guess, is a special, is a filamentous bacilli. Sorry, filamentous virus actually. It's a vector is actually fruit bat or apes or monkeys, and this Ebola virus is mainly found in the African countries because it has created an epidemic there. So transmission is close contact with the blood or secretion or other body fluids of infected animals or infected human beings. Humans to human transmission, close contact with the infected secretion or blood products of the humans. I say on the same like coronavirus, there is the patient, infected patient with Ebola virus should be kept isolated. We should not have any contact. Incubation period is about 2 to 12 days. Common symptoms of fever, headache, muscle pain, and sore throat will be there. After some time, there will be abdominal pain, vomiting, and the patient will have severe watery diarrhea. There will be a diffuse erythematous, macropapillary rash, petechia, ecchymosis, bruising will be there. Can lead to shock and death because the person will have severe watery diarrhea. The patient will have hypertension and will have shock and can lead to shock and death. Then mortality case fatality rate is about 25 to 90% case fatality rate is. For the lab diagnosis, serum antibody test is done, ELISA. Then IgM appears as soon as after 7 days. It lasts for about 3 to 6 months. IgG appears after 2 weeks and persists for about 3 to 5 years. Then serum antigen test, ELISA is done. Molecular method, RT-PCR, real-time RT-PCR, and electron microscopy. You see the typical filamentous virus. Virus isolation is done from the growth on the vero cell line. How do you prevent? Prevention is actually better than the cure. So that's why prevention is highly recommended in Ebola pandemic. Actually, you just need to strict hand hygiene, and you should use sorry, it's not PPR, it's PP. Put up personal protective equipment you have to use. Then isolate the patient with Ebola from other patients. Then avoid direct or indirect contact with the bed or body fluids. That's why even doing the testing for Ebola, you should wear a PPE kit. Otherwise, if you have direct contact, you will have high chance of getting the Ebola virus. Then, if traveling to Ebola outbreak area, monitoring for 21 days after return. The person should be kept quarantined for 21 days, and then only after that you should be free to go. The main now next is malaria. What's the causative agent? Causative agent for malaria is actually Plasmodium. It has got 5 species: Plasmodium vivax, Plasmodium falciparum, Plasmodium malaria, Plasmodium ovale, and Plasmodium novelacea. In this, the most severe form of causing malaria is actually the Plasmodium falciparum. And Plasmodium falciparum is responsible for is caused the that malaria is caused as a cerebral malaria or the black water malaria. What's the life cycle? It has got 2 hosts. Definitive host is the female Anopheles mosquito, and the intermediate host is man. In female Anopheles mosquito, only the sexual cycle takes place. In man, a sexual cycle doesn't take place. And mainly, it is a female Anopheles mosquito because male Anopheles mosquito doesn't feed on man and feeds exclusively on fruit juices only, whereas the female Anopheles needs at least 2 blood meals. Because it feeds on humans not because for as food actually. It because the eggs needs 2 blood meals for maturation. So that's why in order to mature the egg and help in egg laying, it needs blood meal. What's the human cycle? It occurs infection by bite of the female Anopheles mosquito. Sporozoites. It's a sporozoid form which causes infection in humans. And these sporozoites are found in the salivary glands of the mosquito. So sporozoites from the salivary glands enter into the venules of man. The asexual cycle goes through 3 stages. There's 3 stages happening in humans. There is the pre-erythrocytic schizogony, then the erythrocytic schizogony, then gametogony. It's called pre-erythrocytic schizogony because this pre-erythrocytic schizogony or is also called hepatic schizogony because this stage takes place in the hepatocytes mainly, and it is called pre-erythrocytic because it takes place before the entry of the organ schizogony into the RBCs. So it's called pre-erythrocytic schizogony. Erythrocytic schizogony because this stage takes place in the RBC, and gametogony later it comes into the blood, disseminates into blood and takes place in the gametes. Okay. The next is pre-erythrocytic stage. That's what I told you, hepatic stage. The site is liver, of course, before the invasion of the RBC, also called exoerythrocytic or intrahepatic or tissue stage. Motile sporozoites leave circulation within 30 minutes and enters the liver. Then these sporozoites are actually spindle-shaped sporozoites. They then become rounded shape and transform into trophozoites. So round spindle-shaped sporozoites transform into oval-shaped trophozoites. So trophozoites is the feeding stage actually. This which undergoes several nuclear divisions to form the pre-erythrocytic zoones. So trophocytes after several molding formation and they form the pre-erythrocytic cystoids. And it is this pre-erythrocytic cystoids which get which contains several merozoites. They contain several merozoites. I'll just show you the photo right now. Okay, see the first one actually the sporozoites enter into the liver. The hepatocytes into the hepatocytic cells, and once they enter the hepatocytic cells, this sporozoites converts into they form the sporozoites forms sporozoites actually forms trophozoites. So sporozoites forms trophozoites, and this trophozoites contains the merozoites. Sporozoites contains and they stay in the hepatic cells. So the sporozoites actually form the trophozoites, and the trophozoites forms the pre-erythrocytic zoones. And this pre-erythrocytic zoones contains the merozoites, and this merozoites is the one which gets released into the blood circulation, and they form the erythrocytic stage. So the pre-erythrocytic zoones contain several merozoites. These merozoites released out on rupture invades the erythrocytes to initiate the erythrocytic stage. So first there will be sporozoites. The sporozoites will enter the hepatocytes, and in the hepatocytes they form from spindle sporozoites to the oval trophozoites. The trophozoites then undergo several nuclear divisions to form pre-erythrocytic zoones, and this pre-erythrocytic zoones contains the merozoites, and these merozoites are Then what the pre-erythrocytic seasons rupture and release the merozoites into the circulation, and in the circulation, the merozoites then invade the RBCs. So this is called the pre-erythrocytic stage. So in pre-erythrocytic stage, the duration is about 5 to 15 days. You got it, guys? Understood, right? Hello?
Yes, sir.
Yeah, both of you are there,
Yes,
right?
sir. Yes, sir, both others.
Yeah,
My audio
okay.
have some.
Okay, fine. So next is erythrocytic isogony. Then now next is the pre-erythrocytic stage is over. The next is the erythrocytic stage. In erythrocytic stage, the hepatic merozoites released attacks the RBCs. Merozoites binds to glycophorin receptors on the RBC surface, enters by endocytosis. Then they transform into trophocytes. So these merozoites, no, again after the entering into RBCs, they transform into trophocytes. And early trophocytes are called the ring forms. They are annular or signet rings in appearance. They contain central vacuole with a peripheral thin rim of cytoplasm and a nucleus. I just show you a trophozoite here. If I turn this, I just show you in another. So they see here, these early trophocytes are offline. And for different species, actually, there are different type of trophocytes. In Plasmodium vivax, you see there's a circular ring of cytoplasm with a central nucleus like a signet ring shape. And even malaria also is same actually signet ring shape. Whereas in Plasmodium falciparum, no, the early trophocytes can be they can have a signet ring, double ring, circular signet ring shape they can have, or they can have an acol form on the RBC membrane also. So this is the early trophozoite stage. First line is the early trophozoite stage of the Plasmodium falciparum. The next one is the late. After some time, early trophozoite, they transform into late trophozoite. Late trophozoites, this what say are the second lines. There you see amoeboid form of cytoplasm is seen with a central nucleus. Whereas in Plasmodium malaria, there is a band form, and in Plasmodium ovale, you have the signet rings form retained there, but the RBC will be actually lice. There will be ruptured RBC. But Plasmodium falciparum won't have late trophozoites in the peripheral smear. I'll tell you why later. So in erythrocytic isogony, the hepatic merozoites release attacks the RBCs. These merozoites just convert after entering into the RBC, they convert into trophozoites. Early trophozoites are called ring form, annular or signet ring in appearance, contain central vacuoles with a peripheral thin rim of cytoplasm and a nucleus. Late trophozoites are enlarged and becomes more irregular. That's why you see in Plasmodium vivax there was a irregular amoeboid form of trophozoites. Then merozoites, these trophozoites, then they have merozoites, they transform into merozoites again. Then these merozoites actually then again attacks the neighboring RBCs and the cycle continues. So malaria pigments are seen. Undigested products of hemoglobin combine to form malaria pigment. Schizogony, there's a late trophozoite undergoes schizogony to produce 6 to 30 daughter merozoites. That's what I told you. Merozoites attacks on the other RBCs. So this schizogony then undergoes growth, and they have each schizogony will have about 6 to 30 merozoites, daughter merozoites. They are arranged in rosettes. They are called erythrocytic schizogony. This then later the RBC ruptures. The RBC ruptures to release the daughter merozoites, and these merozoites then go and attack the other RBCs, and they continue the same erythrocytic cycle. And this intra-erythrocytic cycle is about 48 to 72 hours. So that time, some the patients they will have actually 48. They'll have a break of fever for about 48 to 72 hours, and suddenly they'll have a spike of fever after 48 to 72 hours. That's called as certain paroxysms. Because they'll have a sudden spike of fever about 101 to 102 degrees Celsius with shivering, and this shivering because of the release of the merozoites, and these merozoites then go and infect the what other RBCs. And during this end of this paroxysm, during the end of this fever, right, before taking any antimalarial drugs, and during the end of this fever, you should end of this paroxysm actually, you should go and take the sample that time, because they will find merozoites in this blood sample, and you will be able to detect the malaria merozoite parasite. Then Plasmodium falciparum infection, the later stage of the erythrocytic cycle occurs in the capillaries of the brain and the internal organs. That's why you don't find the late trophozoites in the peripheral smear of the Plasmodium falciparum, because These late trophozoites actually, these early trophozoites, they go and adhere in the blood vessels of the brain or the other internal organs, and they get adhered to the blood vessels, and there on adhesion they stay there and they form the late trophozoites within these blood vessels of the organs, and they don't get released into the peripheral circulation. That's why late trophozoites won't be found in the peripheral circulation of the Plasmodium falciparum parasite. Only ring forms is found in the peripheral blood examination, but not the late trophozoites and cystogenes. Understood, guys, right? You guys understood why Plasmodium falciparum, the late trophozoites won't be seen in the peripheral smear, right?
Yes. Yes, sir.
Yeah, see, I'll tell you once more. Plasmodium falciparum infection, all other stages, no, they take place in the peripheral blood vessels. But Plasmodium falciparum infection, actually, their growth after the early trophozoites, their growth happens in the capillaries of the organs, and they're not released in the peripheral circulation. That's why when you take the blood test, peripheral smear of the person infected with Plasmodium falciparum, they won't be these late trophozoites won't be present in the peripheral smear, but they will be present only early trophocyte stage will be there, because the late trophocyte stage will be present in the organ. They won't be released in the peripheral circulation. That's the basic concept. So next is after there will be gametogony. Some merozoites after entering into the RBC transform into the sexual form called gametocytes. Two types are there, male and female gametocytes, or micro and macro gametocytes. They don't cause these gametocytes actually. They are the ones which infects the mosquito. They don't cause any clinical symptoms in humans. They cause transmission of disease, infective form to the mosquitoes. In mosquito cycle, the female Anopheles mosquito after the blood meal, the gametocyte undergoes further development. Male gametocyte undergo exflagellation, divides into 8 male gametes or microgametes, while female gametocyte develops into only a single gamete or a macrogamete. Male gametes fertilize the female gametes to form zygote, transform into motile ookinete in the midgut, penetrates the gut wall and becomes the oocyst. That's the zygote. It transforms into the ookinete in the midgut, then penetrates the gut wall and forms oocyst. Oocyst undergoes sporogony, produce 4 spindle-shaped sporocytes. The sporocytes migrate to the salivary gland and the cycle is repeated. This is because it's in the salivary gland which the sporogony is sporocyte. Sporocyte is present in the salivary gland, and this salivary sporocyte is the infective form for humans, whereas the infective form for mosquito is the gametocytes. And this is a male gametocytes. After its fertilization with the female gametocytes, the male gametocytes get destroyed, and only the female gametocyte is actually present, and this female gametocyte is the one which matures into the oocyst, and oocyst undergoes sporogony to form sporozoites, and this sporozoites then later in the salivary glands cause infection to humans. So this is a cycle. You can just go through it and you will understand once more when you're revising. So what's the clinical features? Then there is benign malaria. There is a tired of febrile paroxysm. There is a fever, high fever. I told you febrile paroxysm. First there will be fever with shivering. And after some time the fever will reduce. Again the fever with shivering will be there. And there is a paroxysm. And this paroxysm is called as febrile paroxysm. And during the end of this febrile paroxysm, you need to take the blood sample for the peripheral smear. And then there will be anemia. There will be splenomegaly. Fever will be intermittent. Paroxysm corresponds to the release of successive merozoites into the bloodstream at the end of the RBC cycle. There will be 3 stages like cold stage, hot stage, and then sweating. First, there will be the person will have shivering, with cold, clampy area, peripheral limbs. Then there will be hot stage of excessive. There will be the temperature will be so high, you'll feel like when you touch the patient, you feel the hot, where patient's very hot. Then there will be excessive sweating stage. When the fever comes down, the patient will have excessive sweating. Then there will be anemia in this patient. There will be anemia, and the type of anemia will be normocytic, normochromic anemia, because the problem is not with the production of the RBCs. The problem is because the organism invades the RBCs and they cause rupture of the RBCs, normal RBCs, and that's why it is called there is normocytic, normochromic anemia. Then parasite actually induced RBC lysis, splenic removal of both the that's why this is the cause of the anemia, because parasites induced RBC lysis will be there. The next is splenic removal of both the spleen will cause removal of both the infected as well as the uninfected RBCs also, and there will be bone marrow suppression, and there will be because there will be bone marrow will be signaled to suppress the RBC production, and there because of that there will be bone marrow suppression will be there. There will be decreased RBC production, but the RBC produced won't be damaged, or there won't be any problem with RBC. That's why normocytic normochromic anemia is seen. Remember that the anemia in malaria is normocytic normochromic anemia. There will be splenomegaly because there will be excessive lysis of the RBCs within the spleen, because damage to the spleen also. Spleen gets enlarged and palpable due to the massive, and there is due to a massive proliferation of the macrophages that engulf the parasite RBC. So the RBC, the macrophages will be working continuously to engulf the parasite RBCs, and this will lead to the splenomegaly.